Hello, good evening, everyone. It's 6 p.m. in Belgium, so I suggest we start. I would like to welcome you all to the second YCN webinar about adolescents and young adults with cancer. Let me just introduce myself. I'm one of the chairs. My name is Eva Papa, and I work at Ghent University Hospital. I'm a clinical nurse specialist, digestive oncology. And I'm also the YCN representative for Belgium. And I'm also an executive board member of two Belgian national societies of the oncology nurses and the clinical nurse specialists. And I'm a member of the EONS research working group.
Hi everyone, welcome to our second webinar. I am Limze from Turkey. I work as an assistant professor at the Department of Pediatric Nursing at Koç University. Also, I am representative from Turkey in the EONS Young Cancer Nurses. Now I hand over to our first amazing speaker tonight, Dr. Maria. Dr. Maria Keppel is a dependent cancer nurse, educator, and researcher based in the United Kingdom, but originally from Ireland. She has spent the past 22 years in the nurse education, where the 70 of which were spent developing and delivering education programs and engaging in research with the healthcare worker involved in caring for adolescent and young adults with cancer. She engaged with colleges nationally and international to arise the profile of how they might be carried out for the complexity healthcare service. Also, she is the trust the Martin Hospice Working Share sits on the advisor board of the TAAC, a membership organization. She is going to contribute with the presentation from her doctoral research on experience of early career nurses in specialist unit who care for Aya with cancer. And turn off you, Dr. Maria.
Thank you, everybody, for that lovely warm welcome. I'm really thrilled to be here with you today to talk to you about, let me see if I can get that to share, to talk to you about AYA cancer. I could spend all day talking about AYA cancer, but I probably would bore you all very much. But I want to share with you what I found recently when I was doing my doctoral studies, which has been done for about just over a year now. I cannot get this to see if this will work. I think, there we go. Is that better? Right. So yes, I've been around this field of adolescent and young adult oncology for a very long time, and I have been working in a university, but with colleagues in practice and at policy level, building the specialism. So I've been teaching in and around this field for a long time, and I'm an adult cancer nurse at heart. So I don't come from a pediatric background, but this world has taken me into pediatrics. I recently completed my doctorate where I explored the experiences of early career nurses who look after AYA with cancer, but in specialist units that exist here in the UK. And I used narrative inquiry. So adolescent and young adult cancer. So essentially, this is a specialism that has built over the past 25 years. In the UK, we care for young people between 15 and 25 years old in these specialist units. So these specialist units, here's a picture of one on the left, are funded by a charity called Teenage Cancer Trust. So they sit within the National Health Service hospitals, and there are about 28 of them across the UK. And they can have very few beds. Well, they can have anything from 4 to about 15 beds. It depends. But each of these units have also funded clinical nurse specialists who particularly look after AYA with cancer. And in the UK, we also have another role called youth support coordinators. And these are predominantly youth workers or people who come from that type of background, but the purpose of their jobs is to keep the youth focus on the young people that are cared for in these units, as opposed to delivering clinical care. But essentially, what's really important when we approach care for these young people is that we provide developmentally appropriate healthcare. That is a fairly new term that has been used, along with AYA cancer as opposed to TYA cancer, because as the specialism has developed internationally, it's probably more referred to as AYA rather than TYA. And in the past, and even still, we will still talk about age-appropriate environments, which is fine. But when we look at the literature around developmentally appropriate healthcare, we become more focused on the stage the young person is at rather than their age, because you can have a 22-year-old who's very immature and a 15-year-old who's very mature. So we look at trying to meet their developmentally appropriate healthcare needs. And there are 5 pillars to that. And essentially, we have them in these specialist units. Not every AYA with cancer will be cared for in these healthcare settings. But what is really obvious to us is that they are neither children, big children, or many adults. They have very distinct needs of their own because of their age. So in these units that are quite small, they are working within the normal state of nursing and healthcare. We are all facing a workforce crisis. There are shortages of nurses internationally. It's well documented that in cancer care, we have a paucity of nurses. And also we're coming out of a pandemic, and that brings with it very, very distinct challenges still. Even prior to the pandemic, we were beginning to see the literature refer to lots of different terms in and around cancer nursing, such as resilience, burnout, stress. And there's literature in pediatric and adult nursing in and around what's stressful about looking after these patients with cancer. But there's very little, if anything, ever about looking after AYA, particularly with cancer. We know that because we have a shortage of nurses, we can have a patient safety issue. And we know that the demands of our service are just increasing. So because of this, I really wanted to explore the work of early career nurses. So I could have looked at clinical nurse specialists, and I know there'll be plenty of you on the call today, but what I really wanted to do is I wanted to look at the nurses who were delivering care to young people day in, day out, and whose only work is working with them in the clinical setting, as opposed to more senior nurses who can get away from the ward, maybe to go to meetings or go to clinic. But I just wanted to focus on the most junior qualified nurses that look after them. So predominantly they are early career nurses. I wanted to see what nursing was all about, what this type of nursing was all about, in the absence of anything written about AYA cancer nursing. So that was who I wanted to engage. And I had to figure out how I wanted to do that. And I chose a methodology called narrative inquiry, which essentially is all around people's stories and their experiences. It's a nice way to understand people's experiences, because people will tell you a story, and a story can often be remembered long after facts are. So several people have written about the value of stories, and I think we see that in service development, etc. at the moment. But really it's to illuminate the stories of real people and real settings by acknowledging human experience of dynamic and persistently fluctuating states of change. And my goodness, are we going through a lot of change at the minute. So I was trying to recruit during the pandemic, and I had hoped to go into 4 hospitals, but that didn't happen because, of course, it was non-essential research. So I had to recruit via Twitter, and that meant it opened up the floor for many nurses in the UK beyond the 4 original settings that I had to come forward. And 9 nurses came forward, and they represented 6 different settings in the UK. And you can see their age ranges here. They ranged from 23 to 48. I had one male, the rest were female, and some were children's nurses, some were adult trained nurses, and one young woman was adult and child nursing. So their time and working of being qualified was ranged from anything from 1 year to 7, and their time working with AYA with cancer was really no more than, well, one person looked after them for 6 years, but beyond that, it was only up to 1.5 years. So they really were quite early career nurses. When one is undertaking narrative inquiry, you have to think narratively and about stories all the way from the point of when you start interviewing them. So in my head, I wasn't recording interviews, I was recording storied conversations. So I interviewed 9 of them, or we had a storied conversation over Zoom, which recorded everything. And I had to move between their stories, my research question, and what the literature was telling me. So as with a qualitative study like that, I began to look at some of the early themes that were appearing in those storied conversations. And when we're doing narrative inquiry, I used a framework based on 2 authors called Clandinin and Connolly, and they talk about narratives or narrative research having a notion of time. So there's always a time element, as in think of a story, once upon a time. The story always happens in a place, and there's always context in and around that story. So I had to look at all of these things in relation to the stories that these young nurses were telling me, or these early career nurses were telling me. And I ended up coming up with what I referred to as common strands. And here we see 3 common strands. The first one, it may be no surprise, was that the nurses talked to me about the emotion of it all, the emotional range and labor of their work, what it was like to connect with AYA with cancer and their families, and how they coped with that type of work. The second strand that was new was age. Of course, in AYA cancer care, age is really, really, really important. We talk about the age from the get-go because their age is remarkable. They're neither children nor adults. But for the first time, this study revealed something about the age of the nurses. And the last strand led me to determine what AYA cancer nursing might look like. So the things that they told me about was around developing competence as an AYA cancer nurse and working as an AYA cancer nurse. So if I think about the emotion of it all, the emotional range was expansive. The stories they told me about some of the saddest things you could hear, and actually some of the most joyful things you could hear, and actually how much fun they can have in their work. But I referred back to some of the theoretical work of theodosis and emotional labor, where we get paid to do a job. We all get paid to do a job, but actually we do not always understand or appreciate how much emotion we have to give to that job. We all feel it, but sometimes we have to really manage how we do that. So we get paid to manage our emotions, whether we think about that or not. And I began, as I further explored this, I began to see that some of these nurses saw that as a gift to them, and some of them saw that emotional work as a burden. There was no question that this stemmed from their day-to-day working over protracted periods, working with young people and their families, who they got to know really, really, really well. And when we came to understand more about coping, we spoke about how they cope in the workplace and actually how that spills out into when they leave work. So I've just brought you some of the quotations here, and I'm not going to read all of them all of the time, but I will speak of some of the ones that for me were really, really important. Lauren, who was 48, spoke about a time when she was with a young patient who was about to be told their treatment wasn't working. And she was saying, you're in that space and it's really emotional. And you know that you really care about those people and you really want a miracle. And you sort of have eye contact with that mum, and you can see it, her eyes are full, and I could feel my eyes were filling, and I was thinking, it's okay, it's okay. So she was really trying to contain her emotion because she didn't think it was appropriate to sort of break down and have a good cry. And you don't want the transference of your emotions onto them. And I think this stemmed because they were connecting with them. And in fact, some of them spoke about the fact that they will come in as young teenagers to their care, and they may care for them for long enough that they've grown into young adults. So they are growing with them and becoming part of the family because they're getting to know them really well. This is how they perceive it. In terms of coping, All bar one of them had structured support and work, which for me was quite telling. And that structured support for most of them was something they had to go and seek. It wasn't necessarily something that was given to them in work, that was mandated. They had to self-select it. And Jess gave me a really lovely example of this when she said, there's a lady that comes in to support us as well. So she was a psychologist. And obviously the CNS was really good. They help. They're there if we need it. So you have to be really self-sufficient as a young nurse to ask for help, which for me spoke volumes. One of the quotes that will stick with me in this was from Amy, when many of them managed to debrief somehow, or tried to debrief from the minute their shift was finished until they got home. But for many of them, they had family who may have been in healthcare that could help them. But Amy said to me, even my mum was asking me, how is the boy? So there are people outside these nurses' lives, whilst they've maintained confidentiality, are invested in these stories too. I could speak to that for a long time because it was so powerful, and I'm happy to come back to it, but I know I've got a time limit here. The second strand was around age. And we know that in the literature, the patient's age is explored a lot. We know that there are unique needs for teenagers and young adults with cancer, biologically, biopsychosocially, sexually, and so many aspects. The age of young people, or AYA with cancer, is reported extensively in the literature. But the nurse's age was a new finding for us. All bar one of the nurses were 28 or younger. And when we think about the age demographic, we care for these patients up to the age of 25. So a good percentage of these were the same age as the patients. So when we look at culture as part of the social context, what was really strong in these wards, and you could see it in the picture, that there's a real youth vibe. There are definitely things like pool tables. The social space is really important. There are jukeboxes. The vibe on these wards is very, very different because the physical space looks very different. These specialist units don't look like any other clinical wards. And in fact, I can think of some where you literally cross the line and you go from somewhere that looks really funky to like a really funky hotel. And they describe it as that, to just the most clinical stark scenario. So that's really important to bear in mind. So the physical space generates a different feeling. But these nurses were Generation Y and Generation Z. So they were either very close to the patients and their generational well-being or generational status, or close to the parents' age. So when we look at generational theory in terms of the nursing workforce, we can see that there's a real diversity. And I think the literature is telling us that we're losing our young, and we need to try and stop that. And what it also tells us is that older nurses, more experienced nurses, still feel very, very sad when they lose young people or when they're affected by young people, but their coping strategies get stronger. So it tells us that early career nurses will also find this very difficult, but they may not have the experience behind them to help them learn how to cope. Bearing in mind, many of them, when we think of the developing adolescent brain, it is now known that that doesn't finish developing until you're 25 or 28. So there was, in olden days, we used to see all of their behavior as a behavioral issue. How they behaved was purely behavioral. But now we understand that there's a biological basis for how some young people respond because their brains have not fully developed. So here we have young people with developing brains and young nurses with developing brains. So what we're asking them to do is a lot. So some of their quotes here. It did cross my mind, Jess said, that sometimes they'll know whoever's in the charts or whatever, and no one else will. So these nurses began to tell us that they thought this was a really good thing that they were as young as the patients. They perceive it as a benefit, but it also brings with it challenges. So knowing contemporary culture is a way to engage and relate with young people, which is probably easier for younger nurses maybe than it is older nurses. some of the challenges around that were how the language that gets used when engaging with young people and how familiar these young people, nurses and young people, might become with one another. Claire said you also have to be really careful about that sort of nurse-patient relationship whilst also talking to them and chatting to them like you would, like a friend, obviously, but obviously you're not their friend. So their communication style was quite different. And Anna said, I think that at times you risk being over familiar because you're younger. You think that you're the same age as me and I can do this. But sometimes it's actually a really fine line. And some of them told me about some boundaries that they had witnessed or been part of that really were testing and a challenge. However, Lauren, who was the older nurse, felt that when she first went there, I thought, I'm not young enough or trendy enough to sort of hang out with them. But then I thought to myself, you know, sometimes you just need the maturity to care and sort of think, I'll be able to hang in there and sort of say, do you want to talk about anything? So actually it was about how kind you were and how you could engage with a young person, not necessarily about the age. And the last strand, it really highlighted to me how complex and emotive this type of nursing is. Of course, you could argue that for all types of cancer nursing, but here we begin to see a picture of the complexity of that work. Because when you're working with teenagers or adolescents and young adults with cancer, you're not just looking after patients with just one set of types of cancer, like breast cancer or colorectal cancer or digestive cancers or head and neck. You're crossing the span of them because they get different cancers. So it's complex. The treatments are more complex. The fact that they are transitioning between school, university, from pediatrics to TYA services to adult services, there are so many transitions that it's really, really complex. And what many of these young nurses came to these wards as their first job. So they were trying to learn to be clinically competent as new nurses, but often left in charge. And often left in charge out of hours with very little experienced staff around them. So, but they also really wanted to learn about AYA cancer care in general. And all of them aspired to be a clinical nurse specialist. It seems to be the job that people want to have. What they do after that, as we don't know. But I took this work back to looking, I built on the work of Sarah Lee, who's a cancer nurse who was involved in a study here in the UK called the Bright Light Study, where they conceptualized what AYA cancer care was as opposed to AYA cancer nursing. And I blended that with the work of Jennifer Jackson, who wrote about 4 different types of nursing work. And they are organizational work. So as a nurse, you are organizing your shift, who goes on their break, who needs their treatment, how you're prioritizing your care, who needs bloods done, or you're organizing that work. The cognitive work is linked to the organization, but you begin to stack. This person needs this chemotherapy. This means that they'll need these antibiotics. This person needs their bloods. You need to go on your break. So they're having to really think hard, and that stacks and stacks and stacks and stacks. So as a nurse, you will remember you are trying to think of loads of things. And I see it like a high-rise building where the street below gets lost because you're trying to remember so much. So you're cognitively stacking all of the time. The physical labor of our work is much more easy to measure. How many steps you do in a day, how many lifts you do in a day. So we know we physically feel exhausted, but the emotional labor of our work is also forgotten. So when you're trying to manage all these 4 different types of work, they begin to give us a really strong picture of how complex nursing work is, how complex cancer nursing work is, and then the added complexity of looking after teenagers and young adults with cancer. So some of the things that they told me about were Gemma, who was in her early 20s, she said, sometimes I'm the only chemo giver on days or nights. It's really quite stressful to share the workload. And if you're working with somebody who's like newly qualified, I'm thinking, I'm actually the newly qualified, but yet they're expected to deliver really, really complex care. And sometimes she told me that she felt that the matron would come on and she was just looking at a head count of nurses, not necessarily the work that these nurses were doing. And she thought, we are just so short-staffed and the risks are really high. And because parents stay on the ward as well with these young people, she was saying, I might have 8 patients, but I could have 16 people on the ward. And she told me about one day where a parent had a cardiac arrest on the ward and she out of hours, and she was left trying to manage that. She also told me about another day where she said, I can't start this patient's chemo today. I'm the only person on the ward. I don't feel safe. And the next day, the patient started their chemotherapy and ended up in intensive care. So she made the right call and not asking not to give that patient their chemotherapy, but she had huge clinical pressures on her. And Lauren spoke of how emotional the work was. Lauren's the older nurse, and she said, she knew she was speaking with a mum and it was just so sad because her son was being told the treatment hadn't worked. But equally, within seconds, she was having to go and give chemotherapy to another young person at dead on 3 o'clock. So she was absolutely completing with complex care and her emotions at that time. But Brian also saw the value of this in that he could see it as a way of getting loads of skills as an opportunity to progress. So he was seeing this as an opportunity to develop new clinical skills because they need a lot of clinical skills to work in these environments. So this led me to developing this conceptual framework. And along the bottom, you can see that I strongly believe that they are of equal value, that we have to provide organizational work, labor, cognitive labor, physical labor, and emotional labor in our work as AYA cancer nurses. And bearing in mind, I really only looked at the work of the most junior nurses. This is something upon which we can build. The other thing that's really strong is it's central to all of our work, of course, are AYA cancer patients, but also in AYA cancer care, we will have to think of their family, who may, even though they may be over 18 and legally adults, you'll still be dealing with parents, you may be dealing with partners, you may be dealing with their friends, and they're really critically important in developmentally appropriate healthcare for adolescents and young adults with cancer. Further up that, we can see that what's really important is that we think of ourselves and as an AYA cancer nurse, there are personal factors. What resilience do we have? What about our age and experience of looking after these young people? What about personal support systems do we have at home? Is it safe to go home with all of this burden behind us? We also have to think about these environments within which we work. They're funded by charities, so who therefore takes up the responsibility of making sure that the teams within them are well supported and what they look like. The culture of care in these organizations and these units is really quite different. And we need to think about the benefits of that and the challenges of that. Is there a quality part of that? How do we know we're delivering good care? How do we know we're delivering developmentally appropriate healthcare? And how do we know that we have patients at the heart and their families at the heart of everything that we're doing? All of these nurses spoke to me about wanting to learn, and education will form a great part of that, not just to learn about AYA cancer care, but also to learn about AYA in general, because we have to start with where patients are developmentally so that we can build our care beyond that. And we can't do any of this without effective leadership and management and good governance and good support and good strategy that helps to build our services and protect those that work within them, given the complexity of the healthcare systems within which we're working. All of this will help build on our nursing knowledge and competence. We then will build our cancer nursing competence. So we still need to learn to do things like give chemotherapy and support patients going through radiotherapy. That's cancer nursing. That's the essence of it. But what we will do beyond that then is consider the distinct needs of AYA cancer nursing and the knowledge and competence to do that. So in conclusion, I've established that AYA cancer nursing work is uniquely challenging, demanding, and complex. That these early career nurses work within and across many, many boundaries, and they can be occupational, departmental, organizational, and age-related, not including this cancer-specific cancers, site-specific cancers. We highlighted the specific AYA-related knowledge and skills that underpin this specialism. And these stories have now shone a light and given us a new narrative about the nature of this type of work. And in the end, if we don't look after our young nurses, we won't have a profession. And if we don't look after them, our patients won't be cared for, because they're all deserving of a bright future. And I will stop there.
Thank you very much for this lovely presentation. I would like to introduce the second speaker, which is Sue Haig. Sue is a clinical nurse specialist with the supportive and palliative care team working at University Hospital Southampton. About 10 years ago, she was asked to work alongside the TYA service to improve the palliative care needs of young people across the region. The post was originally supported by Macmillan, working 2 days a week. Now she works 1 day a week with the TYA service, attending their social care and MDT meetings. Sue also provides staff support. They are seen as part of the TYA ward team, which in turn makes the concept of palliative care less frightening, aiming to support with symptom control as well as end-of-life care. Something non-work related, she was at the London Marathon last Sunday giving out finishers medals. Sue will contribute with her working experience with TYA YA patients.
Thank you very much. And Marie, thank you very much for a really amazing presentation. That was really interesting. And there was an awful lot of things that I could see and I could relate to. It's really, really interesting. Thank you. Yeah, I've been asked to do this. As I said in my introduction, I've been working with the teenage. I'm afraid I'm going to stick with TYA because that's how I've got it in my head for the last 10 or so years. And I can honestly say it's the most enjoyable part of my job. It's quite an unusual perspective, having a palliative care nurse working alongside the TYA service, and I think that's been quite a privilege and quite insightful of people in front who sort of asked me to do this. Is my screen sharing? Because I've got, it seems to be stuck.
Yes, we can see it.
Lovely, thank you. Just not share, it's not moving for me. Sorry, I've got a problem changing my slide.
That's okay. If you start share, if you go leave full screen mode on PowerPoint.
Okay.
So you can just press escape.
Sorry, I'm being okay. Right, let's start again. Sorry about this, folks.
And then if you share again on Zoom.
Is that working again? Hopefully it'll move. I'm doing something wrong. I'm really sorry. I'm having a real mare.
That's okay. So if you click on your presentation.
Yeah.
And now can you press escape?
There we go. Yeah.
There you are.
There we go. There we go. That's working now. So you know, a lot of people thought, you know, questioning whether there was a role for having specialist palliative care or supportive and palliative care alongside the TYA service. And originally there was a little bit of resistance to it, but then again, it's just being persistent and sticking with it and showing your value, I think. As I said, it's initially was funded by Macmillan for 2 days a week, and we used that as a way of trying to link up all the palliative care services along the south coast region of England, so they knew that there was a service in Southampton, and also develop those resources around, so people knew what was available. It's now substantive, and all of my colleagues within the palliative care team will see young people. I tend to have a handle on most of them because I go to the meetings, so I can add a bit more sort of story and weight to the care that my colleagues get when they go and see them, if there's a bit of background that they may find useful. We're lucky enough, as Marie said, we've got a purpose-built unit, and a day case. Unfortunately, most of the time at the moment the purpose-built unit is full with 6 patients inpatients and their parents. So the things I've learnt by I sort of doing this and sort of thinking about, well, what's important about having palliative care in this sort of setting, and what are the things that I've learnt doing this job over the last 10 years. And I'll come on to some case presentations as well, because I think that's a good way of demonstrating it. And I think for me, it's a case of being prepared. You never know what you're going to walk into. And I think that's one of the most amazing things that is the good and bad bits of the job, really. I've had conversations with young people about what happens to their body after they've died, wondering around what their last words would be, because they don't understand what death looks like. They've never experienced it. So it's trying to explain and explore those issues and going through that with them. The language they use, if they're having a bad day, they'd probably say, oh, it's a bit rubbish, but they might not say that. They'll probably say it's a shit day. And actually that's fine. And you use that language with them as well. Thinking about the alternatives. So I would imagine that most of the young people that I've come across have probably tried some cannabis at least, if not other things, and it's being aware of those. It's not a problem. We just need to be aware that those that they have been having them, because they're, especially with opioids, there are some interactions with cannabinoids as well, so we need to be working on that. Thinking about what your agenda is as a palliative care nurse or any nurse on the ward, but caring for those patients, and then thinking about what their agenda is, and they might be completely different, and it's making sure that we're working on the same track. What's important to them? Team working, great. Sometimes it works really well and other times it's not quite so well. We have had quite a few challenges about different opinions. Some patients, some of the teams don't like the thought of palliative care being alongside their patients, and are quite scared of us having conversations, thinking that we're going to be talking about death and dying. I don't talk about death and dying unless the patient wants to talk about death and dying. So it's again about navigating our way through that sort of those challenges, and I think that's one of the things that has been really strengthened over the last few years. We've really got to grips with that, and it's working really well. I have a huge amount of respect for these young people and what they're doing and how they're managing getting through their treatment, and it's understanding where they're at as much as anything else. And one of the things that we've sort of coined this phrase, visible transfer of trust, is when for example, the TYA-CNS will introduce the idea of palliative care to the family, and they say, oh no, we don't want palliative care, that's all about death and dying, we don't want that. But then they explain that we're really quite good at pain and symptom management, and although the patient is having active treatment, having us alongside them is quite helpful. And so quite often we sort of try and do joint visits. If there's particular challenges about that, we'll try and do a joint visit or introduction together. They'll introduce, here's Sue, she's the pain nurse, she does the nausea and vomiting, that's what she's here to do. And we've coined the phrase visible transfer of trust, does tend to work really, really well. And for those patients who we are aware of who are likely to have a less good prognosis or have a poor prognosis from the outset, we will try and find any excuse to be for an early referral to us. That means that we get to see them when they are well, they get to see us, and if everything is going well and they're doing, we've got their pain sorted, we've got their nausea sorted, whatever, we can then take a step back, and then they realize, and the family realizes, we're not all about death and dying. We're about making things as good as we can for as long as we can. And that helps that trust and learning and everything else. So we've had a lot of experience, and it'd be really useful to hear if anybody has been working with young people recently about an opioid use. We've had a few issues of patients becoming dependent on their opioids. So as we always do in cancer, in oncology, we tend to, in palliative care, we start low with our opioids. We use the oral route rather than the subcut route. But quite often, if they're hematology patients, they don't want them having subcut injections. So we then have to think about using the IV route. And then that's when the trouble starts, if you like. And we've had quite a few issues around that. So it'd be really interesting to see if anybody's got any views on that. Some people have a lot of some patients might have a bit of familiarity about cocaine or heroin or whatever, using street use and stuff like that. And it's again making sort of understanding why we're using the painkillers and why we're not using morphine or oxycodone and we're using neuropathic agents. So again, it's all about the sort of story and history taking and trying to pull things through from there. So patients in the UK and predominantly in the south, around here that we've looked after, have an option of where they want to die. Luckily, some want to die at home, some in hospital, and the options are home hospital or hospice. So our experience in Southampton is that most patients would either prefer to die at home, but some would prefer to die in hospital because they feel safe here and they know the staff, they know that they can get the medications when they need it, and so that everything's on tap, and they like that, and they're usually on the ward, on the TYA ward, and they know all the staff and the family can come and go and they've got all that support network for them. Others might want to get home, and trying to navigate that is, especially if that with medications and that sort of thing, can be a bit challenging, but we can do it and we have done it in the past. And I think one of my cases will demonstrate that as well. And we've had a couple who have chosen to be in the hospice. And again, most people think that the hospice is for old people. They're not. They take anybody. We've also got a young person's hospice about 15-20 miles up the road from us, so not that far, so they can access that if possible, if that's what they wanted. But most people geographically would prefer to be at home or in the TYA unit, if at all possible. So I've got a couple of cases for you. So we've got Harry, who had he was early 20s, and he'd had AML and 3 lapses, and he kept going with his treatment because he didn't want to let the doctors down. He had really bad GVHD, and actually that's what caught up with him in the end. And he kept going with all of his treatments. And this was there was a couple of other patients, Harry and 2 or 3 others at the similar sort of time, who had been fighting with their cancer, with their cancers for a long time, and they were well known to the ward. And it was we had a specialty doctor who just started working there, and she was working with these patients. And we realized that at that point we were really fighting to sort of say, you know, what does the patient want and where do they want to be? Harry actually died in hospital, probably not where he wanted to be, but he was okay with that. And he had the support of the ward team around him. And one of the other patients at the same sort of time, he was actually on intensive care, and we brought him down from intensive care to die on the ward, and that worked really well. These are all patients who have sadly died, which goes with my job, but that's not always the case. And certainly with Jo, we had seen her on and off throughout her treatment because she had had flares of leukemia, which caused her quite a lot of symptoms. So we helped sort her out whilst they were waiting for the chemo to do its job, and then we would pull back again. So we had on and off contact with her through the day, through her disease journey. But Jo was an amazing young lady who I call it the longest day because it is one of the longest days of my working career, and I will never forget it. And a real privilege. She was in hospital, and we had tentative plans to get her home on this particular day. Myself and my consultant went down to see her, and she was barely rousable, and we thought she's not fit enough to travel, so we cancelled the transport and cancelled the discharge. We then had a phone call about 3 o'clock in the afternoon saying we want to go home and Joe wants to go home. So consultant and I trogged back down to the ward and had the conversation. We were very blunt with the whole family. There was Joe and her two brothers, her dad, her parents and her boyfriend there. And we had a conversation about that she may well die en route. So, but that was all fine. They wanted to do it. So at about 5:30 in the afternoon, we were dodging through the traffic on the M27, and then onto the streets, onto sort of narrow roads in the New Forest. And we got Jo home that afternoon. She had 12 hours at home. She was well supported by her family, and her GP came to visit whilst I was there, which was because he'd known her since she was a little girl. And I think that was, to me, that was one of the best days of my career, because we got her where she wanted to be and all of her family were there, and it was just as good as it could have been. So, you can see the sort of, that's one of our learnings from Harry, to being quite chaotic and not in the best way, really. Jo being a little bit more chaotic, but getting to her to where she wanted to be. And then we had Rich, who was a real character. He had relapsed ALL. He had a poor home and social situation. He pretty much lived on the streets, had spent a bit of time in juvenile detention, and his care was, he had no home to go to, so he spent most of his treatment life on the ward, on the unit. So as Marie was saying, he'd been on the ward for a long time, and he was quite a lad. He'd certainly tried and experimented on any recreational drugs possible. But again, when his disease relapsed and he was dying, he chose to die on the ward because he knew all the staff there and he felt safe there, and that felt right. And actually, because he had such a poor home situation, on one occasion, it was permitted that the ward representation was higher than it would be normally. So, and I'll come back to that in a mo. And then we've got Josh, who was a sarcoma, and again he had a really tough time with managing his pain. And we had to think outside the box with his pain management, and we tried opioids, we tried the neuropathic agents, but he would get real bad flares of pain whenever he moved. So he ended up being on Entonox because his pain, that was the best way of managing his pain. We probably would do that slightly differently now because it's about 5 years ago. But he had a massive cylinder of Entonox at the end of his bed, and he would suck on that whenever he was going to try to get from bed to chair. He again died on the ward, and he was quite happy with that. And that's something, as when we started on the unit, when the unit opened, we were not anticipating. One of the things I said about, so as a unit, if a young person dies, the things we do is at least the CNS and or a social worker or a combination of will go to the funeral representing the ward team. So there's always representation at a funeral for any of these young people who die. And I will always do a debrief plus or minus psychology if we've got anybody around, so we can have a sort of moment to pause, remember and reflect on those young people. And is there anything that we can learn from it? And also make sure everybody's okay, especially if they've died on the ward. As I said, I always do staff support on the ward. I offer it. I always check everybody out. It's usually alternate Fridays, thereabouts. But again, it's to make sure that it's about sustainability, and the ward nurses know that they can always catch up with me ad hoc. And, you walk on the ward and you can feel things aren't right. You can say, oh, how are things? Do you want to chat? And they'll, because I'm around so often, they'll have a chat and tell me what's going on. And that works really well. I've mentioned staff support there. So my other take-home message is that we talk about young people dying of cancer. here in the UK, approximately a GP who would, God knows how many patients they see in their working career, but they're only likely to come across one young person who will die of, or who will have cancer in their working career. So that's really important message meant to remember. They're not just you know, a tip of the iceberg. It's almost like a snowflake on top of the iceberg, really. And also for the patients that we see in the hospital, we're seeing the sickest of the sick. There's lots of other young people out there having their treatment without any problems. And that's really important to remember for sustainability and staff support type thing. And I think that's me done. Have you got any questions? Sorry, I've rushed through that once I got started.
Thank you very much. I think we will do the questions at the end of the 3 sessions. So if you have questions, please type them in the chat, and then Ramsey and I will ask the questions afterwards. The last speaker is Dr. Katarina Sedova. She is a physician in internal medicine and project manager at Bulovka University Hospital in Prague in the Czech Republic, where she is launching and managing a new project, Oncology Care Assistance. Katarina is also the founder and CEO of LONO, a non-profit organization dedicated to the prevention of cancer, mental health disease, and also cardiac diseases. Moreover, she experienced cancer treatment herself. We are pleased that she is going to tell us about her experience, what AYA cancer patients truly need, what helps, and what we should perhaps avoid in our care. On top of that, we are curious to hear about how LONO works. Hi, Dr. Sedova. We have some questions for you. The first question is, how old were you when you received your cancer diagnosis?
Thank you very much. It's a pleasure to be here, and thank you for the wonderful presentation. I really enjoyed it. So I was 22 when I was diagnosed with ovarian cancer, pretty rare type. You probably know that ovarian cancer is mostly a case of older women. So I was pretty shocked actually to be diagnosed at such a young age.
Yeah, okay, I can imagine. Was it on your regular appointments, or did you have symptoms or problems which led you to visit the physician?
So I went to regular checkup in December, and then 3 months later, I had some trouble with my period. I had irregular period, and I also felt really tired. I am a sports woman all my life, so I felt really bit weird, really tired. So I visited the gynecologist once more. At first, I actually thought I was pregnant. And then she discovered a lump or cyst on my ovary. And we decided to check it within 3 weeks, and it got much bigger. So it was quite aggressive type of tumor.
Okay, can you tell us a bit more how it was to hear the diagnosis so young? What feelings did you have?
So it was quite a shock, as I mentioned, maybe a little bit more for my family than for me, because I was already 4th year medical student. So I was more curious about what type of tumor I have, what the receptors, what's the treatment like. So I have so many questions for my oncologist and the oncology team at the faculty hospital. And I actually, they were not prepared for the questions, first of all, because most of the young patients who don't study medical school, they just ask maybe 1 or 2, and I had 20. So I really expected them to really answer all of them. They just told me I'm a little bit maybe too concerned, and I was quite angry with them, because too concerned, like what does it mean, right? I have a cancer at 22. So yeah, I had so many questions at the time.
Mm-hmm. What did give you strength during your fight for after receiving a diagnosis for cancer?
Mm-hmm. So maybe the fact I studied medical school, I just wanted to finish the school. the studies. I already made through 4 years, and I had 2 more to be done with the study. So it helped me a lot. I actually wasn't allowed to interrupt the study, so I had to go to school through the whole period, which was kind of hard, but my peers really supported me and helped me to go to classes and helped me with like administrating the medication, etc. um yeah, I think and also just the fact I was so young, I just wanted to live, I wanted to get married, I wanted to have kids, I wanted to travel, I wanted to go to study abroad. I later went to Harvard Med. So yeah, maybe those on the top of my mind.
Okay, it must be hard to both be studying and then going through treatment. Did you have any positive or negative experiences with healthcare professionals you want to share?
Yeah, as I mentioned, the time to answer the questions, especially for young adults, there were questions like fertility, sexuality, doing sports, like all these things. So just taking this, I think that's the most pressing questions in medical sector is the time, and time with your specialist. So I think the time was crucial, and also that they really didn't pay much attention to the fact I am a young woman. They really treated me like the 70-year-old woman with ovarian cancer, but I really want to talk about egg preservation and all these things, considering fertility. So maybe also paying attention to one's age, right? We talked about it today. But I also have many wonderful experiences with staff, especially with nurses and with care coordinators who were really supportive. But at the time, I really knew all the things that will come because I was a medical professional already. So I just told them that they should pay maybe more attention to the other patients, but they really offered help at every stage. At the beginning, when they told me the diagnosis, as well as after the surgery and the treatment. So I was really fortunate to have this type of environment, but it's not very common in every hospital, and that's why I'm launching the care coordinators program at Bulovka, where you will get an assistant when you're diagnosed with breast cancer. We will give you your contact person that will guide you through the whole care. It's not medical professional, it's more like coordinator. So they don't have medical background, but they can like order examination and guide patients through the dates and procedures.
Sounds very interesting. Can you maybe give some more details on how we can support young cancer patients as a nurse, or what should we avoid, or what should we do better?
Yeah, I think we mentioned a lot of things earlier, so I totally agree with taking the time, being empathetic, really take all the concerns into account. And I think you as a nurses, you do that because you're very empathetic people, but not all the doctors, right? They just they're undermining your thoughts, your concerns. They're saying things that this is not important, this is not important, this you can go through. And especially as male doctors, there's not that higher level of empathy. So I think that's important, just to listen, right? What to avoid? Yeah, maybe that I would say that for this and this question. Yeah, that's maybe what I would say to that.
Okay, thank you. And you became a physician. Does your own experience affect how you do your job now?
Definitely. I'm also internal medicine specialist working in the emergency room, so we also don't have that much time to talk with patients, but I can maybe I'm able to triage patients, right, where we need to do things, but and where we can sit and really talk about things. especially during the day service. So it really influenced my personal experience, really influenced my today's work. Also because I'm usually the one who will discover the cancer and who should tell the bad news, right? Then we send the patients to oncology. So actually that's how the system works in the Czech Republic, that the cancer is usually discovered by some internal medicine doctor, and then we do all the staging, and then we send the patients to oncology. So and unfortunately, we didn't really receive any special training how to tell the bad news. So I had to go to my to pay for certain seminars either in the US, UK, or in Czech Republic on how to do that. So that's what I advise all my younger residents or like peers to really go through such training, because you can help the patient, but you cannot help the patient at the level when you go through the training. So yeah, it really influenced my work. And I'm also a huge promoter of prevention, as you mentioned at the beginning. So I talk to my patients about mammography, colonoscopy. I ask them about smoking. I do the short interventions on stop smoking. I ask them about alcohol. So I spend, I think, 1/3 of my time with patients talking about prevention.
Okay, do you have what cancer screening programs do you have in your country? Can you tell us a bit more about that?
Yes, so we have three, like right now, 4 official screening programs. We have mammography once in 2 years after 45 years of age. We have a cervical cancer program. We do pap smears every year from the age of 15 till maybe 70. And then we have colonoscopy after 50 years of age, once in 10 years, or you can do the FOB test once a year or once in 2 years, depends on your family history. And then we have GP checkup once in 2 years, but only 25% people go there. It's especially for like cardiovascular health, but also they give you the paperwork for colonoscopy and mammography. And this year we launched a lung cancer program. So we screen patients from the age of 55 to 75 that smoke, and we send them to X-rays. And if there is any suspicion, we send them to a low-dose CT. We're just piloting this program this year, so we will have first results in the end of the year, and we will see if we will continue with that. And for 2024, we also plan to have official PSA screening for prostate cancer, which is done right now, but it's not really well reimbursed by the insurance company.
Okay, so you're already doing a lot. I would also like to go more into detail about your organization you established, LONO. Can you maybe tell something about that, how you established it, why, and what does it do?
Yeah, thank you. So I established LUNO after I was diagnosed with cancer, because when I told my peers about my experience, almost nobody would visit the doctor as soon as I did. So and maybe they wouldn't be here today, because I was told that if I would come 2 months later, I wouldn't be here today. So that really scared me. So I started hosting educational workshops in schools, companies, and festivals. And with 1,050,000 people educated during the last 7 years, we are like the #1 educational organization in the Czech Republic. We managed to reach more than 2 million people online, because we are very active on websites, social media. And this year we also launched a preventive mobile app that we want to scale through Europe and potentially globally. The app reminds people on how to or when and where to go on preventive examinations, and also guide the user through prevention and healthy living, I would say. So the organization is run by me and my professional team of marketing people, project management people, and fundraisers, as well as by young doctors and medical students that do the examination in the schools and companies. We do not only do the oncological program, but we also talk about cardiovascular health, mental health from the pandemic, and as well as reproductive health, healthy teeth, diabetes, so the wide range of preventative topics.
Okay, sounds very interesting. I think it would be also an added value in Europe and globally, if I hear it. Regarding the younger generation, are they responsible enough for some self-checks, or do they just feel more immortal at their young age? What do you think?
I think the second one, I also felt immortal 22, and I still feel immortal when 30. Yeah, I think they feel definitely, and it's natural, right? And they will feel it in 10 years the same. But I think it's changing also with the trend of lifestyle medicine. I'm not sure about the US, but Europe is definitely the healthy lifestyle is trending, and that's helping us, right? More and more people are searching for healthy eating, exercise online. We can see the statistics. So it's getting better, and what's our strategy is to use open, positive, and communication, and also the language people can understand. We actually, to draw attention to the topic, we named the first campaign "Boobs and Balls," hashtag "Boobs and Balls" in Czech "Prsa koule," and it has thousands of mentions on Instagram, and it became a phenomenon in Czech and Slovakia. And thanks to this campaign that's going on for 8 years now, we managed to draw attention to the preventive topic itself. So, and it's really the language of the younger generation. And we actually managed to do a secondary effect that the younger generation thought their parents and grandparents about prevention. And we have 60 plus people that send us a message that we help them discover cancer at early stage, not only in breast and testicle, but also prostate, colon, etc. Just they visited a preventive checkup they've been neglecting for some time. So I think that's the answer.
Okay, thank you. I would really like to thank you very much to give some or to tell us your experience. I don't know, Ramsey, were there some questions in the chat?
Yeah, we have some question. The first one I think is for Sue. Why does the hematology team ask to avoid subcutaneous medication? I can only think about the risk of bleeding with the low platelets or risk of the infection, but sure, oncology patients are at the same risk, and the risk of the insertion for IV cannulation would be even higher. If these are the reasons choosing the IV route, and what option do you have at the award level and apart from the IV paracetamol?
Thank you. And thank you, Katharina, for your amazing presentation. That was really good as well. Indeed. So the reason the hematologists are more anxious about clotting or about infection prevention and bleeding. So that's why we don't tend to use them in there. The oncologists don't tend to be, are aware of it, but don't tend to be quite so concerned about it. I guess it's sort of the nature of the cancer disease. Most of the patients who we come across have got either central lines, PICC lines going into arm artery, arm veins, etc. So we tend to use those. If patients are going home for at the end of life, then the district nurses and those sorts of people won't be able to use IV route at all. So we have to take that into consideration when thinking about discharge. But it's mainly because the hematology teams are very infection and bleeding averse predominantly. Hope that answers.
Yeah, okay, thank you, Sue. And I think the second one is for you. Sarapina, we have no debriefs following the often traumatic deaths on the ward. Have, have mentioned it to management, but they just give us a number of staff psychologists. How could I go about encourage this on the ward?
So we struggle to have any psychology in Southampton as well. Unfortunately, our psychology service is pretty minimal, really. I think it's finding somebody who, it doesn't have to be psychology. It could be one of the palliative care team. It could be somebody from chaplains, but it's somebody who you can have a service for. In the UK, we have a service called TRIM, which is about trauma risk management. So anybody who has a traumatic event can then can be referred to the TRIM organisation, who will then can help do debriefs and that sort of thing. So that's something we would offer as well if it was particularly traumatic. But it's finding somebody who, because trying to find psychology anywhere is quite difficult, I think. So it's trying to find somebody who can provide that level of support for the ward services and who has a presence on the ward and knows people on the ward.
Thank you, Sue. Maria?
Sorry, that was my young adult son just coming in
Yeah,
from work.
yeah.
I think from some of the stuff that I've been reading around, and I've been looking at this in quite a lot of detail, I think this comes up maybe with some of the questions that follow later. I think we cannot underestimate the value and benefit of us checking in on each other, purposely and actively doing it, as opposed to just thinking about somebody might have had a bad day. I think we often haven't an awful left in the tank to give everybody else anything, but the value in that is remarkable. So I think starting within your teams is really, really important. I think that there's also a lot to be said for supervision, restorative supervision, opportunities where you can even just have reflective conversations, even if that's over a cup of coffee, where it's a very purposeful opportunity where you will sit and talk about something that has just happened or how you might be feeling about work. If you have access to psychology, and I think very few people have, some people can manage to do that, others don't. I think that can work really well. Where I have seen it working well in a TYA unit is when you're being really age appropriate. The wake times are different. So wake times on an AYA unit are much later because the circadian rhythms of teenagers are that they wake up much later. And that's not a laziness thing, that's a biological thing. So actually in a lot of these units, they don't wake the patients until later in the day. They don't have a ward round first thing in the morning. So they use the early morning time to have their debriefs. So again, it's about thinking about how you might use the time that you've got to be your most effective. There's also a lot to be said from shared learning when you do education things on these units. So actually you might be talking about something very clinical, like Sue might be coming to talk about the use of subcutaneous drugs, but actually there'll be an awful lot more learning that will go on in and around that. Yeah, that would be my addition to that, but yeah.
Thank you so much for your amazing contribution. And the third question is again, Sue. Michelle asks, you are provide such an honorable job. I know that we all as cancer nurses have the different thinking, and we know that sometimes the best outcome is patient who is dying surrounded by his loved ones and as peaceful as possible. However, still, what is your physical vision after such a tough day? What should you recommend to the young cancer nurses?
I think it's finding your way of debriefing and sort of looking after yourself. As Maria says, I do the support sessions on the TYA unit at 8 o'clock in the morning, so I catch the night staff and the day staff, so that works quite well. If that's what my normal support session times is. I think psychological hygiene, it's just acknowledging that you've had a bad day. If it's a really, really busy day, make sure you have time to go to the toilet. and go for a wee. It sounds really stupid, but even then that gives you 5 minutes to get your head, a couple of minutes to get your thoughts together, and that's really helpful. And I think it's about finding your way of de-stressing. I go to boot camp and I run, and I've got friends who I chat away to, but I don't tend to talk to my outside of work. I don't tend to talk about work at all. I've got a really good supportive team, which you would hope for in palliative care. And, I could say, oh, that was really horrible about, whatever. And you can offload to, my colleagues are always willing to do that. And it's finding your go-to person if you need to offload. And it might be that you've got a really good rapport with one of the colleagues who started at the same time as you do. It's making sure that you find your person to talk to and offload to, if that's as one way of coping, but equally doing your sort of physical stuff as well to get those energies out. And it's also, from a UK point of view, we have to re-register or revalidate every 3 years, and doing your revalidation reflections are always really helpful, because it does make you stop and think about and work things through.
Okay, thank you, Sue. And next question is yours. Sue, yeah, all of the questions regarding you. But that's amazing. Thank you for your sharing your experience. Do you sometimes have teenager, young adults younger than 18? How do you respond if the parents don't want their child to know that they are dying?
I think most young people have an idea of what's going on with them anyway.
Yeah.
And one of the things we do look after anybody over the age of 16 with any life-limiting illness. So we would always have the conversation with the parent present. We wouldn't talk to the parent without having the young person. We wouldn't talk to the parent first and then the young person. We would always have the conversation as one unit. So it's about how you frame that and how you ask those questions and what do they understand. I'm presently having conversations with a young person who's in that age range, and it just blows my mind as to what she's telling me and talking about. And it's about building up that trust and that rapport with them.
Yeah, Maria.
Yeah,
Thank you, Sue.
we've been doing. I'm involved in a literature review looking at communication with teenagers and young adults with cancer, and there is without a shadow of a doubt, there are many, many different things we need to think about as healthcare professionals when we're communicating with adolescents and young adults with cancer. And one of them, well, a couple of top tips really. One is that we need to start normalizing as they're aging that we will speak to them on their own and we'll speak to their parents on their own, because we don't just get them to 18 and then drop the parents. So it's really, really, really important that they recognize that we are helping them grow into independent young people. So normalizing that there will come a time where it's really important, we want to have a conversation with you without your parents. So the parents need to hear this as much as the young people do, because the parents might want to say things to the healthcare professional that they don't want the young person to hear, and vice versa. And if you're thinking about care in a developmentally appropriate way, and you're thinking about some of the adolescent health issues before we get to the end of the line, and actually even including, Sue, I would say, when we're thinking about using assessment frameworks to help us frame some of these conversations. And in adolescent health, there's one that gets used commonly, and that's called a HEADS assessment. And Sue brought it up in her talk when she was talking about the use of cannabis. So actually, if you've got a young person and they're doing cannabis, they may not want to tell you that in front of their parent. So it's really important that we create that space. The other thing I would say so it's about managing what we call a triad. So we call this triadic communication. So you're managing a supporter, whoever that may be. It may be a parent, and it may be a partner, it may be a friend, a pal, the 3 Ps as I call them. So it's it's all about managing that. And often the reason the parent doesn't want to wants to stay in the room is because they're afraid. They're really, really scared. So it's recognizing and tapping into using your most effective facilitative communication skills to enable the opportunity for the young person and the parent to build a trusting rapport with you so that they feel safe to express themselves, so that you will handle that safely and carefully, that they'll feel they can talk to you. And it's a skill. It's like driving. You just don't get in a car and drive. You have to practice it. You have to understand some theory, and you have to get some feedback. And it's the same, but we see communication as a soft skill. It's everything but a soft skill. You need to be trained to do it and have the opportunity then to reflect on how well that went, because the majority of the reflective conversations I have with people in practice is when some things like that go really badly wrong and you feel dreadful. But it's not, maybe nothing that you did, but you need the opportunity to reflect on things so you can learn from them.
Okay, thank you. We have no time. Do you have any final message for our participants? Katerina, Sue, and Maria, for the final message for our participants.
Thank you.
You are welcome.
Thank you. It's been great to see you all.
Thank you for the invitation, and continue doing such a great work. It's really necessary, and the patients will appreciate it.
Thank you. We have come to the end of our webinar, and also I want to share our next webinar. Our next webinar is the secondhand smoking. It will be held on the 14 November in 2021. Please don't forget to register. And I want to special thank to our speakers for your presentation and for your shared experience. And thank you for all our participants for your attendance. I want to remind you again, our third webinar is the secondhand smoking, will be held on the 14 November 2022. I wish you a nice rest of the resting. Thank you for your participation.